Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Jim Lancaster from Main Street Health about rural collective care, primary care that shows up. Let's get started.
If you're a resident training right now, it's easy to think that the hospital-based model that you're in is the only model that's available. But we're here today to let you know that actually we're living through a great reinvention of primary care with the different payment models, all the regulatory shifts. And today we've got Dr. Jim Lancaster here to talk about some of the great innovation that's happening in rural healthcare, probably the greatest opportunity for primary care in the last couple decades. So Dr. Lancaster, welcome. It's so good to see you.
Dr. Faisel and Dr. Dan, it's good to see you all. I was so honored at the invitation to join y'all today. But I'll hang up if you call me Dr. Lancaster again. It's either Jim or Dr. Jim. That's all we're going with, okay? But truly, it's an honor to be here and appreciate it. And gosh, I've listened to y'all's podcast this week while I've been on the road. Y'all know I travel quite a bit. I've been through 5 states this week, and it's only Thursday, visiting with practices. And those are rural town car miles. Those are not airline miles, and you're exactly right. I tell primary care residents when I get to speak to them and medical students, small town primary care, even independent primary care, it's still possible. Don't let people tell you it's not possible. Some of the happiest docs I get to see are in small towns doing just amazing work.
Yeah, and you've lived through it. You've lived through, I remember, you're living through fee for service. You worked on the payer side, and now you're doing this great work in rural America. You've never really reacted to change. You're always kind of somebody who's shaping it.
Oh, well, thank you for saying that. I think we all have to adapt, don't we? And, I've been listening to, some of your podcasts, just been so inspired this past week. And,
are you sure that was me and probably
No, it was you. It was you. And it sounded just like the two amazing physicians I got to meet at Primary Care America now a few months ago. Primary care is a special calling. I call it a labor of love, when I'm describing it in practices and out just in social settings. It's hard work, but it's great, rewarding work.
For the students listening, Jim, they're still being trained in the regular kind of billing model. Like there's that putting the 99213s and all that. Could you talk a little bit about just the revenue stability, like with the value-based care model, that's possible that you could never see in the fee-for-service model?
Thanks for asking that. And we may have spoken from when I was in practice, at the advent of value-based care back 20 years ago, and leading an independent 25 physician practice or being a partner at times, not leading. But, value-based care, I simply looked at it as I really try hard to take good care of my patients. If there's some additional recognition and reward there for that work, I'm going to do the work anyway, right? I'm going to do everything I can to take the absolute best care of my patients. If there's something else on the table there, of course, we want to access it as best we can. It helped keep our group independent 20 years ago with here in Nashville. You can see the skyline in the background, Nashville rent, Nashville staffing prices, medical office buildings, but we were independent. And that really helped us survive. We didn't have to go and say, hey, we're not going to make it. You're going to have to employ us to the hospital system to whom we were dedicated, but we were also happy being independent. So advent of value-based care, additional revenue for primary care, doing great work for quality as well as outcomes. And that's really what it's all about.
How did your staffing models change? That's one thing I've seen in the value-based care, like the groups that made the switch over to value-based care, that the mindset of having an entire team, like people have different credentials, but they bring a different, it's like they bring a different angle to each patient you're looking after.
I think the way I would probably think about your question, if I'm understanding right, and I might not be, but I think for larger practices, especially the really large practices, they can absorb those staffing costs, that extra expense to, if you will, kind of chase that additional revenue. That's kind of been the model. One of the reasons I joined Main Street, and I think other people in the industry trying to help small town, medium-sized, non-metropolitan practices, especially the independent ones, I think one of the things I see is that they need that extra help. And those practices, if you're in a, 2-doc, 10-employee practicing, hiring another person to do quality is a huge step. It's just extra on the shoulders of your team. So it's one of the reasons I joined Main Street was our model of kind of health navigators across the nation, helping not only do some of that work, but also help with patients focused on seniors and real help. And I know we're going to talk a little bit about that, like the recent storms and some of the challenges and just extra help, extra support. Dr. Dan, I know you will relate to this. One of the things I always say is that when I was in primary care, like these seniors, these complicated patients who I loved, I had taken care of for years, they needed this extra help. Families and patients would come to me for help. But I didn't have a social worker, right? The social worker was in the hospital, had to be admitted to really get access to the social worker. So it was my receptionist, Kathy, my two MAs, Rhonda and Roanna, who were with me for years, us trying to do that extra work. I was filling out bus forms for disabled patients. We do the work because we love our patients, but that extra help sure is appreciated when we can get it.
Well, and I would imagine if you were in a rural practice, it's not only getting the resources to hire that health navigator, it's how do you train them? How do you know what they need to do? And then when you start looking after these metrics, I mean, I've got a full panel of patients that I'm seeing. Where does the time come from to think about, I've got to get all the intricate details for each of these quality measures? How are you going to track that and follow that? And I could see where working with somebody like Main Street would really allow you to focus on your patients more and less on the administrative burdens that go with that.
That is so true. And I talk about that out in the small towns kind of all the time, the fact of we have hundreds of health navigators. We have over 100 full-time salaried health navigators just in Tennessee, not to count well over 500 kind of across our 20-state footprint. But we've got them separated into teams. We're coaching them. We are training them. We are supporting them as a team, even if individually they're in different small towns and different practices every day, working right alongside the primary care team. Yeah, Dr. Dan, you're exactly right. So it's one of the things that gives me I'm humbled getting to participate in some of the work going out, kind of supporting my colleagues and trying to make sure, to your point, Dr. Faisel, there's a next generation of primary care, right? Especially in small town America.
Yeah. I mean, I the young doctors, when they're first finishing residency and they're coming out, remember when you first finish and you're coming out and you want to show that, hey, I know some things and I can now practice and I can do all the things. The social issues, it seems so daunting. I mean, it's hard enough to prioritize all the different pathophysiology that's going on, and you're a new doctor. What you just spoke about with the health navigators helping, like you have so many in Tennessee, like how would that change the day-to-day practice for a resident right now who's finishing and is considering, going into rural America or versus going into a bigger city? Like how does having access to these health navigators change their day-to-day experience being a rural doctor?
I think being a primary care physician or non-physician PCP, regardless, I think one of the things that I believe, I've been honored to serve on the Tennessee Medical Association's Physician Wellness Committee, and we talk about physician burnout. And, in my mind, I think much of that is because our cohort of training, I think so many of us came out of training and we felt like we had to do it all. Whereas I do see now that hopefully residents coming out of training, younger physicians are learning more the team approach. And I think part of the burnout is docs trying to put it all on their shoulders, having trouble accepting help. Dr. Hoff was talking about the autonomy of physicians in one of your recent podcasts. I loved his podcast or his appearance on your podcast, but autonomy is important, but so is the collective impact of a practice working together. So I think physicians understanding, I think one of the other things that causes a lot of burnout in physicians is that feeling of helplessness about some of the health determinants and social disparities and challenges of my patient needs Eliquis, but they can't afford it and I don't know what to do. My patient doesn't have a ride to the cardiologist. You all were speaking about transportation to colonoscopies, those kind of challenges. And that's one of the things that I think, and we're not the only person in the industry doing it, but the health navigators we're supplying out into these practices can help with some of those challenges, helping patients navigate some of the non-clinical challenges that I think weigh on physicians because, again, number one, we care for our patients. I could make the perfect care plan. I tell docs, your job is to make that care plan. I want to help supply someone who can help you make that care plan happen.
Right. Writing it down on a piece of paper doesn't actually make anything happen, right? I think that's one of the things that you spend a lot of time going through your training about writing the perfect notes, yet most people never read those notes again once they're written. So writing down so you'll know enough about what you were thinking when you were there, but then spending time on how to operationalize those plans. I mean, and part of what made us think about you coming on is we were having a planning call, and it was during that storm when there was all the ice. And I had just seen a Facebook post from a friend that lives in Nashville, and he doesn't live in a cheap portion of Nashville, but he'd been without power for like 4 days. And I was thinking that just made me think of you and think of all the practices around Tennessee. Lawrence Gonzalez is a author who writes about survival, and I'm sure I'm butchering it, but he has this idea that most of the time we're in our society now, we're riding around in our climate controlled cocoons, whether it be an airplane, a car, in our house, and we're only one bad turn, one mechanical failure, or one bad storm away from being back basically living like our ancestors did, 4 or 5 generations ago without indoor heat, without indoor plumbing. And, I would think for the seniors and for the people trying to care for those seniors, you're trying to care for your own family and that's happening. What was it like in Tennessee? Because, Tennessee doesn't typically get big ice storms. So what has this been like for you and your practices there?
Well, Dr. Dan, you brought up so many important points. You stole half the things I was going to say, but that's okay. I'll come back to them anyway. I'm glad we think alike. But, seniors are vulnerable, right? And more vulnerable than myself and my family. It's an inconvenience. It was for me and my family losing power for a couple of days, but we were fine. I was like, yeah, we got sleeping bags. We got a gas stove. We're fine, right? We got plenty of food in the pantry. It's going to be fun, right? We'll make fun of it. But seniors, looking through the stories of, I think it was 13 persons who last count I saw passed away because of the ice storm, during the ice storm across Tennessee, multiple in metropolitan areas, multiple in rural areas, but multiple of them were in their 90s that I saw, right? And I saw a quote about the fact that natural disasters don't cause vulnerability. They expose vulnerability. For seniors, when getting out is a challenge already, and you live down a country road, or you live in a very metropolitan area in Nashville that may be a food desert as well, but seniors who have trouble getting out on a good day, seniors who have trouble staying warm in the winter on a good day, food insecurity, where seniors living on a fixed income may not have 3 weeks of food in the pantry. It quickly becomes a crisis. And, even for us, again, our health navigators that we have, they don't sit in a call bank in a metropolitan area in Chicago or Nashville. They're out in these small towns. We had multiple navigators who couldn't get out of their house, who lost power for a week. One of our navigators had a small generator. That's all she and her husband and family had. They were walking to the gas station to get gas for their generator because they couldn't get out to the road. You think about that in a 90-year-old, and you understand quickly when the vulnerability and danger occurs. But inspiring stories, right? There is again, challenges create some opportunities at times as well. Multiple primary care physicians that we work with, that we're partnered with, actually got out and picked up their staff, including our navigators, so they could open their office. They didn't want their staff driving, but they got out and picked them up in a couple of different locations. And, that's inspiring to me as a doc. Actually, so Dr. Faisel, we talk about how rare this is, right? Reminds me of 1993. I was an intern here at Vanderbilt, which is directly behind me a couple of miles. I just got back into town this afternoon so I could have stable internet for the podcast, which I knew was critical. I don't have that a lot, but 1993 was probably the last worst ice storm we had. And it reminded me that my best friend, Steve, who was an intern with me, and myself, we both had 4x4s, four-wheel drive vehicles. And we got out every morning and picked up other interns to get them to the hospital for the better part of 2 weeks because they couldn't get there. And knowing internship, we also didn't want to do it by ourselves, right? We also wanted that help. We're like, nope, you're coming. Let's go. We'll be at your apartment on 21st Avenue in 10 minutes. But it's that kind of banding together. But that's healthcare, right? That's what we do. Other things, I think, responses to the storm. Working, some of our navigators and staff at our clinics had first responder emergency personnel in their families. So worked with emergency personnel getting water and food and picking up people who weren't safe. We had some navigators who we couldn't get in touch with for multiple days, and navigators who couldn't get in touch with their, in one case, like a grandparent for several days. So it was definitely scary times. And snow and ice are different. Like snow's pretty, but ice storms are different. And it hit Nashville as well. My other Tennessee-based physician colleague that I work with Main Street, lives in a nice neighborhood, but was without power and internet for over a week. So challenging.
But it does highlight the difficulty of getting care into the rural areas and what it takes to do that, right? I mean, the docs who went to get the staff knew that they needed the team, right? They couldn't do it by themselves. They could have, it would have been easier for them to drive straight to the office, but they knew they needed the team members to be there with them so that the patients could get the care they needed. So that is huge. I mean, doing a little bit of Googling about Main Street, it's interesting. You have a lot of the major insurance companies are investors, right? They're usually competitors, but they have all taken an interest in the work you're doing because they understand how difficult it is to provide this rural health care. And so they're people who usually are competing or collaborating with you to help their patients get this care because they know how difficult it is for that to happen. Why do you think that's happening? I mean, it's pretty amazing when you hear that. I don't know who it is, Aetna and United. I don't know which companies they are. I just know there are a few different ones that are investing in you. And these are people who generally don't get in the same room and play nice with each other.
Honestly, Dr. Dan, I don't know either. I'm just out here in the field all day.
Yeah.
But, I do think, Faisel, you mentioned it. I came from the plan side in a role leading value-based relationships prior to Main Street, joined Main Street because I heard the mission. I'm from a small town and heard the mission. And I thought about my mentor when I was in medical school. And I was like, wow, if I can get out there and help those kind of docs and get them extra help, extra resources, extra reliable revenue, that'd be a great mission I would love to be part of. And I know from the plan side, those small rural practices, it's easier to engage a 300 provider PCP system than it is 300 different solo doc practices in the region. So, I think it's hard to get out that far out into the rural areas. I think hopefully we help with that. We help coach so many practices, incredible practices, but they might not have been as savvy with value-based care. They've been doing it on their own, that we're able to kind of help and support and coach. Faisel, you mentioned on the call with Pivot, just real quickly, with Dr. Richmond, that you knew her mom, and that was such an inspiring. I'm going to send that podcast to my son, who's a first-year medical student. He was about 8 when I left practice to go coach value-based relationships on the plan side. And I sat him down and was like, son, I'm going to be leaving the practice to go and work for this other company. He's like, so you're not going to be a doctor? And I was like, no, I'll still be a doctor. You're still going to have your patients? Well, no, I'm going to have to give up my patients to go to this other opportunity. He said, well, we're still going to have this office though, right? I'm like, well, no, we won't have this office. He was like, what are you going to do? And I was like, well, son, I'm hoping to serve doctors, help get them extra help, get them extra support, try to bring them the things that they need to help them be more successful across the state. Hundreds of doctors across the state I'm going to help. And he kind of looked at me as, 8-year-olds do. And they sometimes call you out. And he said, I don't know, Dad, like you keep talking about serving doctors and bringing them stuff. It's like, sounds like you're just going to be a butler to doctors. And I said, yeah, son, maybe so. And that's okay. So this opportunity, Dr. Dan, gives me the opportunity, I feel like, to serve a lot of our colleagues and bring them help and resources that had not reached them before.
Well, and if I could imagine if I were in one of these rural practices and you showed up to talk with me about value-based care, having done it yourself, that would allay a lot of my fears rather than somebody I don't know that the insurance executives wear Brooks Brothers anymore, but wearing a Brooks Brothers suit, showing up with their polished loafers and never had any dust on it, that in the rural area, not knowing about the life that I was trying to live and the patients I was trying to care for. So I would think it sounds like you all have put the right team together to do that coaching. You've walked in their shoes. You know what they need to do to be successful in this work.
Absolutely. And I know the challenges of, we still see a lot of primary care practices who throw in the towel, And I got asked last week by a potential new partner. And let me be honest, there are lots of others out there doing great work. It's not just us. And I love to see it. And I'll come into practices and they'll say, oh, we're already getting help from some other company, maybe Wilvana or Aledade or whoever it might be. And I say, great. I just want to make sure you're getting help, right? Good for you. If they're helping you, wonderful. Like, you're my colleague, you're an independent doc. I want you to stay successful. I would love to help you, but I'm just glad somebody's helping you.
Yeah, because that's what's driving so much of the frustration and the burnout. Like, doctors they want to manage illness and disease in real time. They don't want to be caught up doing all these other things, taking them away from our calling. Like that's one of the things that comes up quite frequently with, that the doctors are getting burnt out from all these complicated patients and stuff. And no, it's not, that we find that very interesting. That's what it's all the stuff around patient care that distracts us away from our calling, that burns us out.
You are so right. And there are so many puzzles separate from clinical care love the value-based revenue. We've already talked about how much I love it, and I've dedicated this part of my career to helping advance it, but it's complicated and everybody's got a different puzzle. So trying to say, hey, look, we're going to take care of all that. We're going to put the puzzle together for you. Just go take care of your patients. We're going to help you know across your patient population who hadn't had a mammogram, who hadn't been in if they've been in the hospital, who didn't come in for their wellness visit this year. Because I know my front desk person, already mentioned her, Kathy, she's still dear to me and still a Facebook friend, as are so many of my patients. I didn't really give up my patients because hundreds of them are still Facebook friends with me. But, she was so busy answering phone calls in primary care, she didn't have time always to call out for those annual physicals. So extra help. Primary care needs extra help.
Could you talk a little bit about, I feel like every week I'm learning some new amazing AI tool, using tools like Open Evidence. I remember when UpToDate, I thought UpToDate was just, they couldn't be anything better than that. And then of course my favorite still hands down is the ambient AI listening and generating the notes. All the busy work of having to put information into the fields, God, that drove me crazy. I would love to learn a little bit or hear a little bit about how you all are using AI in innovative ways for many of these practices that I'm sure they may not be completely up to date with all these cool tools that are available.
I think that's a great question, Faisel. And I had a great conversation with a friend who is executive medical director for largest primary care group in Tennessee, who had implemented and not one of our partners, but he's a dear friend, and had implemented an ambient AI documentation solution. And there was cynicism, but within, I think, 60 days, he said basically all of his physicians had adopted it and was life-changing. And because we all spent hours and hours and hours documenting our progress notes. I used to tell people, like, the office hours of my clinic schedule, that 8 hours is half my day. Right? The other half of my day is looking at test results and calling patients and looking at consultant notes and finishing up my notes for the day and all that stuff. So I think that's an incredible advance. I think we're trying to figure out how to support practices with that. I think one thing that I'm really proud of what we've been able to do is we have a huge database of clinical data, and we're able to present to PCPs data on their patients that we believe they have not been aware of. Not just the chronic conditions that are already in the note, but one of my favorite examples is one of our partners in Jamestown, Tennessee. Beautiful little town right up next to Kentucky, right next to the Big South Fork National Wilderness Area. If you ever get a chance to go, it's incredible. He's lived there his whole life. He's been practicing for 30 years. And over the space of a few months, some of the data we presented, the way we present it to them and kind of clinical things we found that they have built. We found 2 abdominal aneurysms in his patients that he didn't know about, because this is what frustrates primary care, right? Even in Nashville, I would have a specialist 1 floor up from me who would see my patients 3 times and never send me a note. But small town docs get forgotten a lot of times. The patient bounce, right? So, that's clinically impactful when I talk about that, because letting that PCP know, hey, 2 patients had an abdominal aneurysm. You didn't know about it, but here's the CT scan. We know you've never submitted that code. We want to make sure you know, because that changes that patient's life if they call at 3 p.m. on a Friday and say, I've got abdominal pain, and you didn't know they had a AAA, right? So that's one of the ways I think we are helping, consolidating data from specialists in labs and imaging and hospitals and presenting it to say, hey, We don't think your patient was hospitalized, in Nashville, 200 miles away, because they never told you, but here's the information. We're going to help you get them back into the office. That's impactful for outcomes. And I always do the mother rule, right? At the hospital I was at, I ran peer review kind of committees as medical staff president for a while, and I always use the mother rule, right? Is that the care you would have wanted your mother to have? And I just think about, like, if my dad's going to a primary care doc in small town Mississippi, where I'm from, that's the kind of thing I want his doctor to know. And also these navigators. One of the reasons I joined the company, I was like, geez, she had a wonderful doctor in my small hometown before she passed away. But I was like, man, I wish my mom had one of these health navigators to help her with some of the things when I'm 3 hours away in Nashville and can't get there that often.
Well, I mean, you're making primary care the strategic center of the healthcare system again. I mean, primary care always was. Just something happened along the way, and it got all just reduced down to, like these wellness visits and referral renewals. But I feel like with value-based care, we get to be doctors again.
I always tell PCPs, like, hey, that's your patient, right? And no offense to specialists, love specialists, but I would loan my patients to specialists to help with the things I needed help with, but they're always mine, right? And people used to ask me, like, what's primary care? I don't really know what that is. What does that mean? Like, you're not like a neurosurgeon or an orthopedic surgeon. It's not glamorous, right? But I say, it's kind of like going to the beach down in the Gulf Coast, right? You're from Florida. You live in Florida, Faisel. Kind of like going to the beach, picking up a handful of sand and not letting a single grain drop through, because every patient's got 20 grains of sand. When I left practice, I had 3,800 active patients. Heard y'all talk about a panel of 2,500 and some of kind of the full risk models, and even that's a lot. It's a lot, but again, it's a labor of love, and we love our patients, and you're trying to keep track of all that.
For the medical students, we run into so many times, the student loan debt. My God, it's unbelievable how high. I can't even begin to imagine having like a student loan debt even more than what many people's first mortgage even, I mean, just very, very high student loan debts. And so meet these students who say, well, I really, really would love to be a primary care doctor, but I'm not pursuing it. I'm not pursuing family medicine. I'm not pursuing internal medicine. I'm going a different route because I worry about the burnout, that primary care doctors end up experiencing. For those students, why should they feel optimistic now?
Well, I would say all students listening, you can find me on LinkedIn. I can get you basically rural loan forgiveness programs to come be a PCP in Tennessee tomorrow. One of our partners told me last year, and he's one of my best friends and great partner, and they have an archipelago of 30 independent clinics across the Cumberland Plateau, which is Nashville to Knoxville, that are part of their CIN ACO, if you will. And he said, Jim, I could put 20 doctors to work tomorrow in our practices. We just got to find them. So it's there. There's incredible, honestly, working in rural America, small town America. It's a beautiful place to live. It's interesting. Physicians in small towns often still carry a level of esteem and respect that some may feel like is not present in kind of big cities, if you will. That may be a Mississippi person term, but the big cities, small town, and the opportunities there, loan forgiveness is there, salaries are there, practices need physicians to come take over. I mean, how many practices do I know across the region? I could literally overnight send you hundreds where there is an average PCP age 65 to 75, right? They need that next generation to come in and take over that small business practice. It's already set. The patients love the practice. It's that if you build it, they will come. Well, it's built.
It's built.
Come be the next generation of small town primary care docs, because it's a wonderful life. Was that good?
That was beautiful. Yeah, I was going to ask you, like, what 10 years from now, what does successful rural primary care look like? But it sounds like it's already there. They're just waiting for people to come show up.
Yeah, I think they don't know about it, and I've talked to most of the residency programs, I think in Tennessee, some of the people that, help run the residency programs, just to say, hey, I can send you pictures of these small towns and where are your residents from? Like, let's connect them. I love that matchmaker role of like, oh, you're from McMinnville, Tennessee, but you didn't know that a 50-year practice is dying to get a doctor to come back home, right? So it's very possible. It's not just Tennessee. It's kind of across the nation. I think that small towns want doctors to come back. And let's also say, I really shouldn't say that without saying the future of primary care in America and small town America isn't just physicians, right? And that's okay. It is also PAs and nurse practitioners, and that is okay. I told one of my colleagues that I work with a couple of years ago. We had visited, probably 300 practices across Tennessee. And I think I was asked kind of my opinion on nurse practitioners and primary care. And I said, to be honest, if I had to rank the top 10 practices I would go into and establish as a patient, as we sit here and talk, half of them would be NP-owned and run practices because of the patient care approach, the passion for medicine. We all know most of medicine we learned on the job. We didn't necessarily learn it in residency. I'm internal medicine. I think y'all are family practice, and I'm jealous because I came into primary care, right? And I'm like, oh, I can put a central line in you. I can aspirate anything. Like you put you in the ICU, I can take care of you all day long. All those family practice procedures y'all learned, I'm like, oh no, I can't sew that up. No, that's
Well, Jim, I have to tell you, thank you so much for taking the time. I mean, you've always been a proactive kind of person, but even the work that you're doing right now, helping these practices, just with all the things, all these things outside of patient care that kind of get in the way of patient care. It's beautiful what you're doing for the practices, but also, I didn't realize like how much of a help you are also for the doctors who are nearing retirement, to also be that person, like a connector with the young doctors for these communities where there's so much need. So you've always been this proactive kind of architect, and I see that, it doesn't matter what you're doing, you're always going to be helping.
Well, thank you, Faisel. I appreciate it. And I think greatly of y'all. I am hooked on your podcast now, and I got plenty of time to listen. Man, I had so many notes on some of the ones you have been through, Dr. Hofstetter, and, the leaving the system better. I think was that maybe Dr. Fisher?
It might have been Dr. Elliot Fisher. Yeah.
Well, it's a wonderful, wonderful operation. And it really feels like a celebration of primary care and what is possible again. And thank you all for helping lead that charge. I am so appreciative of getting the opportunity to support you all. As you can tell, a lot of my interests are not necessarily with Main Street, but the connecting young physicians that's just a personal desire to try to support kind of primary care in small town America for the next generation. But I appreciate so much the opportunity to be here. It's really an honor, and it's inspired me being here today, but also just getting to know you all and listening to the podcast this past week as I drive across the region.
Thank you so much. Thank you.
Thank you.
Thank you, Dr. Dan. Faisel, thank you so much.
What are your thoughts on rural collective care, primary care that shows up? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.